many of these cases. واحنا عندنا كتير جدا من closed عندنا ناس كتير can be treated without surgical intervention with the medical management as normal. طبعا disclosure, I have no disclosures. The objectives of that lecture, it's by the end of that lecture, I hope that you will be able to understand the fundamentals of assessment of head injury patients, and you will be able to differentiate and manage mild, moderate, and severe head injury, either pre-hospital setting or in hospital setting, and to be able to differentiate between penetrating and perforating head injury and manage it, and management of closed head injury as well, management of simple and comminuted breast fractures, and management of traumatic CSF leak, either conservatively or by other simple measures if required. طبعا اي حاله في التروما احنا دايما بنرجع ونتكلم على ال ATLS guidelines. I hope that all of you can understand Arabic. فانا هتكلم most of speed يعني half just to make it easier and simpler for whoever listening. طبعا الاسسمنت بتاع التروما المين كورنر ستون اللي هو ال ATLS guidelines اللي هو ABCD, which stands for airway management with cervical spine immobilization. B stands for breathing, C stands for circulation management, and D stands for disability, and then exposure, and then reassessment, and then the secondary survey. احنا طبعا مش هنتكلم هنا على الاير واي ولا breathing ولا circulation. However, this is very important in management of head injury. يعني ما ينفعش to start to treat head injury without treating the airway. ليه؟ لأنه العيان if he can't breathe, there is no oxygen will go to his brain, the brain will swollen, then the brain edema, then high intracranial pressure, then we can expose to secondary brain injury, and even the worst case scenario العيان ده ممكن يحصل له brain herniation and so on. وهنفهم ده برضو أكتر وهنتكلم عليه تاني في سلايدز تاني. المانجمنت بتاع الديسابيليتي دايما بيحتاج first of all assessment عشان أنا أعرف إيه اللي بيحصل مع المريض بتاعي. هل هو عنده serious cranial problem, brain problem, or if he's stable enough to be managed later on or to be assessed later on. فأنا عندي 3 parameters بقيم بيهم العيان اللي هم برضو جزء من ال ATLS اللي هو GCS، وده بيفرق لي بين المايلد والمودريت والسيفير تروما، والبيبيراري رياكشن هل هم ايكوال ولا لا، او هل هم رياكتيف ولا لا البيوبلز، واللاتراليزيشن ساين، وهنتكلم عن اللاتراليزيشن ساين اكتر بالتفصيل later on. وبعدين بعد ما بنخلص البرايمري سيرفي we will normally do secondary survey to make sure that there is no other injury like scalp injury, like signs of skull-base fracture, like signs of CSF leak, like depressed fracture, and so on. Will main purpose from that lecture to prevent secondary brain injury. لأنه دايما حتى ده المين purpose بالنسبة للنيوروسيرجن في ال higher centers that already the brain has already primary insult and our aim to prevent secondary insult. طبعا في برضه فكره مهمه لازم تبقى في دماغنا في الكونفليكت زون او الوور زون. احنا في عندنا نورمال واي اوف ترياج اللي هو عندي مثلا ونفترض 10 مصابين في حادثه، انا بفرزهم ازاي؟ بشوف الاير واي بتاع العين الاول او بشوف الاير واي والبريثنج والسيركيليشن. فور اكزامبل لو انا عندي مشكله لواحد عنده اير واي بروبلم، ده العيان الاول اللي انا هتعامل معاه سواء قبل المستشفى ان انا I want to protect his airway، او هنقله الاول لانه العيان ده he is more serious than others. وبعدين بشوف العيان اللي عنده breathing problem like tension pneumothorax or whatever, and then circulation problem like bleeding, hemorrhage, shock state, and then the disability patient will be the fourth category. طيب على سبيل المثال لو أنا عندي triage for 200 cases in a casualty. For example, I got a bombing for a place, I have 200 cases. وانا عندي مستشفى مش هتستحمل الرقم ده من المرضى، وانا ما عنديش اي كباسيتي في العمليات بتاعتي اتعامل مع كل الناس، ولا في الطوارئ ان انا اتعامل معاهم، ولا البري هوسبيتال سيتويشن يسمح لي ده. طبعا في هذه الاحيان بيبقى القرار صعب، لكن احنا we are triaging depending on the people that they most likely survive. فانا بتعامل مع العيان الموست likely will survive، والعيان that he is less likely to survive I will not deal with him. I'm sorry, are you able to hear me? If you can't hear me, just notify me, please, Muhammad. I can change the internet connection. However, I can put it on my phone. Assalamu alaikum. Hello? Hello? Can you hear me? Can you hear me? Okay, great. So because it was mentioned that no one can hear me. So I'll complete. If you can't hear me, just drop something in the chat box so I will read it. For triaging, it has different way of triaging, and this depending on the casualty itself. Is it mass casualty or is it just small RTA that we can deal with it? طبعا في تقييم بيختلف برضو ما بين النيونيتس والبيدياتريكس والادلت. نورمالي احنا ما بيحصلناش نوع من الشوك مثلا افتر هيد انجري في الهيد انجري الا اذا انا عندي سكالب لاسريشن with significant bleeding، او اذا العيان ده عنده neurogenic shock which is due to spinal injury. There is no kind of hemorrhagic shock in because of brain bleeding unless this patient is in neonate, because in neonate they can lose a lot of blood in their scalp or subgaleal or intracranially, having a large head compared to their age. أما الشوك state, it won't happen in adult unless he has a significantly bleeding lacerated wound in his scalp. Again, we should have a way to neuro monitor or neuro observation للعيان ده. طبعا neuro observation again it will go back to GCS pupils at residual sign، وممكن في ال secondary survey اللي هو proper neurological examination. We have some other ways of neuro monitoring which could be available in some places or some hospitals, and during the mass casualty or conflict zone, or could not be available, and then we have different way to monitor. We'll speak about that as well. بعد كده هنتكلم على critical care management principles in the coming few slides. لما نرجع نتكلم على GCS بس ممكن اغلبكم يكونوا عارف الكلام ده، لكن احنا عايزين to make it simple، واللي مش عارفه برضه ممكن يعني to refresh it with us. اول حاجه احنا بنتكلم على البيست eye opening، best verbal response، best motor response. best يعني ايه؟ يعني انا على سبيل المثال اذا العيان بيقدر يفتح عين واحده والعين التانية ما يقدرش يفتحها، فانا هعتبره ده 4 لو هو بيفتحها spontaneously. على سبيل المثال لو العيان عنده normal flexion في ناحية أو abnormal flexion في الناحية التانية في إيده التانية على سبيل المثال، فأنا هحسبه إن هو normal flexion، it will be the best response. إحنا عندنا 3 component للجي سي اس، component بتاع الأي opening والverbal response والmotor response. The best GCS will be 15، which means 4 in eye opening, 5 in verbal response, and 6 in motor response. The worst GCS will be 1, that the patient has no response, he's unresponsive. Sometimes we can't assess that component. For example, the patient is intubated, so it will be cannot assist or intubated. طيب في ايه اهم جزء من الجي سي اس؟ هل هم equally important؟ يعني على سبيل المثال لو انا قلت لك this patient GCS is 8 which is 4 for eye opening and 1 for verbal, and then it's again 3 for motor. Is it equal to the patient that he got 6 in motor, 1 in verbal, 1 in eye opening? No, it's not equal. The best important response will be the motor response. And the most important one, why? Because this will لأنه ده بيبين لنا الوضع العصبي للعين. هو ممكن يكون عنده مشاكل ما يقدرش يفتح عينه لأنه very drowsy أو shy to light أو عنده fractures around the eye أو عنده pre-orbital edema. فأنا I can't assess, or some people will say he can't open it, or due to oculomotor nerve palsy. كذلك الverbal maybe because of intoxication or direct trauma to the to the verbal to the اللي هو ال speech cortex. لكن الموتور it's very important and it's not equally important. لو أنا مثلا قلت 8 while the eye component is full while the M motor is really affected. It's very important also to mention the breakdown of the GCS. طيب احنا نتكلم عليهم بسرعة. الاي اوبننج لو هو بيفتح عينه سبونتينيسلي هيبقى 4. لو احنا لو هو قافل عينه بس احنا لما بنقول له افتح عينك بيفتحها هيبقى 3. لو ما بيفتحهاش للفيربال فاحنا لو ده عملنا بريشر للسوبرا اوربيتال area he open it so it's 2. if there is no response it's 1. طيب لما نروح للفيربال، الفيربال لو هو بيتكلم كلام عادي وعارف هو فين وما فيهوش مشكلة هتبقى 5. لو بيتكلم confused speech يعني هو بيتكلم بس الكلام بتاعه جمل غير منطقية فده هيبقى 4. لو بيتكلم كلمات فقط مش جمل هيبقى 3. لو بيعمل أصوات زي مونينج كده أو بيتألم أو يتأوه فور بين هيبقى 2. ولو مفيش أي ريسبونس فور بين هيبقى 1. يبقى الأولاني أورينتد confused words ده كله هو بيكلمني وأكلمه. لكن لو ما بيكلمش خالص words فأنا ممكن أعمل له painful stimuli he can do some sounds فايتس 2 and then 1 for nothing. الموتور ريسبونس الماكسيمم 6 لو هو obeying commands. obeying commands يعني أقول له ارفع إيدك، حرك إيدك، ارفع افتح بقك، لسانك وما إلى ذلك. في بعض الأحيان ممكن المريض يكون عنده weakness أو عنده affection للسنسيشن عشان cervical injury فإحنا دايما لما بنيجي نعمل له البينفول ستيمولاي بنعملها له في الهيد اللي هي في السوبرا أوربيتال ريجن. يعني بندوس هنا لو أنتوا شايفين. طيب الموتور obeying command 6 localizing 5 normal flexion 4 abnormal flexion 3 واكستنشن 2 ونون 1. طبعا انا جبت سلايد تانية علشان اوريكم الفرق بين الفليكشن والابنورمال فليكشن لانه في ناس بيكونفيوز بين بوث. الفليكشن العيان بيبعد دراعاته عن جسمه وبيعمل فليكشن من غير ما يفليكس الريست، يعني الريست نفسه في وضعية عادية. لكن لو هو عامل abduction للارمز with flexion for his wrist مع extension للليجز ده بنسميه abnormal flexion to pain. وده معناته ان هو جي سي اس الموتور كومبوننت ناو 3. طب سوري الموتور كومبوننت هيبقى 3 والابنورمال اكستنشن اللي هو extending his arm and extending his elbow with adduction and flexing his wrist as you see there. فده الديفرنس between all of this. اوكي فاحنا مهم جدا الجلاس كوما سكور لانه هيقول لنا السيفيريتي اوف هيد انجري، والسيفيريتي اوف هيد انجري طبعا المايلد هيد انجري اللي هو 14 و15 جي سي اس، والمودريت اللي هي هنقسمها من 12 سوري من 9 الى 13، والسيفير هيد انجري اللي طيب ايه الفرق بين البيدياتريك والادلت؟ في فروق بسيطه اللي هي هتبقى الفروق بتاعت السبيتش. لانه في الادلت احنا عارفين هو هي كان سبيك فاحنا هنتكلم باورينتد سبيتش وكونفيوز سبيتش وما الى ذلك. لكن في بعض الاطفال اللي هم مش ما بيقدروش يتكلموا كلام واضح، فاذا الطفل alert و doing the same activity و communicating the same normal communication that means that he's V5. and if he's less than usual according to his family so this will be 4. if he cries to pain only this will be 3. if he moans to pain this will be 2. and there is no response will be 1, and the others will be the same as the adults. طيب احنا كده دلوقتي اتكلمنا على الجي سي اس. الاذر كومبوننت اوف اسسمنت will be inequality of the pupil. وليه مهمه inequality of pupil؟ لانه لو العيان ده عنده undilated fixed pupil in one side, this is warning sign انه العيان ده كونينج سوري عنده انكل هيرنيشن. يعني ايه انكل هيرنيشن؟ يعني الانكس جزء من البرين كده، التمبرال لوب، بيضغط على البرين ستيم، ولما بيجي يضغط على البرين ستيم بياخد في سكته الاوكيولو موتور نيرف اللي هو بيعدي من التنتوريوم لفوق في المكان ده، فبيعمل يونيلاترال دايليتيشن لون اي. طيب هل ده ممكن يكون موجود في ناس طبيعية؟ ممكن، بس احنا عارفين ان ده هيكون المريض صاحي ويتكلم معاك وهو عارف ان ده بري اكزيستنج بروبلم قدامه. او ممكن يكون العيان ده مثلا حاطط قطره عامله له بيبريري دايليتيشن، غالبا ده هيبقى بايلاترالي، وغالبا ده برضه احنا ممكن نعرفه من البيشنت ريبورت، وده طبعا دي حالات نادره مش بنشوفها. لكن في حالات التروما احنا بنكون very concerned ان العيان ده يكون عنده unilateral dilatation في one pupil especially لو هو عنده lateralization sign. يعني ايه lateralization sign؟ يعني عنده مثلا unilateral dilatation في الاي على الناحيه اليمين، وعلى الناحيه الشمال من جسمه عنده weakness او he can't move the upper and lower limb on the other side of the body. يبقى ipsilateral fixed pupil and contralateral weakness in upper and lower limb. ليه ده warning sign؟ ده معناته انه في المريض ده عنده some sort of increased pressure in the ipsilateral side whereas ده في نفس الناحية اللي هو فيها dilated fixed pupil. طيب ده معناه انه ممكن يكون عنده expanding hematoma مثلا زي extradural hematoma او subdural hematoma او worsening contusion that needs decompression and so on. اوكي؟ طيب في برنسبلز مهمه برضو في المانجمنت بتاعت الهيد انجري اللي هو السيريبرال بلاد برفيوجن. ده مهم جدا انك تعرف هو ده عباره عن ايه. طبعا احنا عشان نوصل دم للمخ في عاملين مهمين جدا. المين ارتيريال بريشر اللي هو ضغط الدم اللي هو بيطلع الدم للدماغ، والريزيستنس بتاعت الدماغ اللي هو الانتراكرينال بريشر نفسه اللي هو البريشر اللي جوه الدماغ. فانا عشان اوصل دم كويس للمخ لازم يكون عندي very good main arterial pressure، خصوصا لو انا عندي very high intracardiac pressure. معنى الكلام انه management of circulation it's very important to prevent secondary brain injury. حتى مع الناس اللي عندهم expanding hematoma intracranially I need to push the blood upward there, so I have to maintain the mean arterial pressure. The bottom line, you have to treat shock always. That's major part in treating the head injury. طيب في حاجه تانية اسمها cerebral autoregulation، لانه طبعا احنا عارفين ان المخ ده جوه closed box اللي هو السكال، وفي 3 كومبوننت بس موجودين جوه السكال دي. اول كومبوننت اللي هو 80% من السكال جوه السكال ده برين، وحوالي 10% بلاد اللي هم سواء ارتيريال اور فينس بلاد، وحوالي 10% كمان سي اس اف فلويد اللي هو 150 مللي سي اس اف فلويد. طيب لو انا عندي اي expanding hematoma او worsening contusion او whatever the cause of increased intracardiac pressure، ايه اول حاجه هتحصل؟ اول حاجه هتحصل البلاد سبلاي اللي رايح للبرين هيأفكت اول حاجه الفينوس ريتيرن هيزيد علشان يقلل البلاد اللي جوه، وكمان البلاد سبلاي نفسه هيبدأ يقل. السي اس اف برودكشن برضه هيقل. ده كلها كومبنساتوري ميكانيزم للبرين علشان يقلل الانتراكرينال بريشر. زي ما انتم شايفين في الصوره لما يحصل بليدنج هيموريج تيومر وات ايفر هيبدا الايه الفينوس ريتيرن درينج يزيد، والبلاد سبلاي يقل، والسي اس اف درينج يزيد، والسي اس اف برودكشن يقل. هيفضل الميكانيزم ده maintaining لحد some extent. بعد هذا الاكستنت هيحصل ما يسمى بالهرنيشن سيندروم. يعني البرين هيبدأ يتحرك من one space to another space. زي ما انتم شايفين هنا في الصورة عندنا expanding extradural hematoma pushing the brain. ايه الهرنيشن سيندروم؟ ممكن البرين يروح من مثلا الليفت تو رايت اللي هو subfalcine herniation زي ما انتم شايفين. ده مش بيبقى سيريس قوي الا اذا هو ضغط على الانتيريور سيريبرال ارتريز وسبب اسكيميا. وممكن يحصل ما يسمى بالانكل هيرنيشن، انا لسه شرحته اللي لسه اتكلمت عليه، اللي هو بيضغط على البرين ستيم وبيضغط على الاوكيولوموتور نيرف، فبالتالي بيعمل unilateral fixed dilated pupil ipsilateral on the same side, and because it's compressing on the brainstem it will affect the contralateral side in terms of weakness. ممكن يحصل حاجة اسمها cerebellar tonsillar herniation اللي هو herniation of cerebellar tonsil into the foramen magnum, and this will cause death. وده طبعا impending problem لأنه if it's pushed a lot on the brainstem the patient will die as well. وفي ما يسمى transcalvarial herniation لما يكون في defect في السكال نفسها، فممكن البرين نفسه herniate outside, and we can see that later how to manage the skull fractures. لو احنا رجعنا سلايد كمان، السلايد اللي هي فيها الويفز، ده طبعا اي سي بي ويف. احنا في بعض الاحيان بنحط intracranial monitor. I will show you that monitor to later on how to monitor the brain. ده طبعا normal wave، والnormal wave دي ال B2 representing compliance of the brain. I won't go into further details. I just want to show you that below 20 millimercury this is normal wave. If the patient start not to be a compliant brain, what will happen? The wave will be persistently high, more than 20, and the B2 will be higher than B1 and B3, which is pathological, and this is causing this due to loss of compliance of the brain. Okay? طيب نرجع بقى، ده احنا اتكلمنا على الاوتو ريجوليشن، نتكلم بقى ترايجنج اتكلمنا عليها برضو، وطبعا الكورنر ستون اوف مانجمنت will remain ABC as long as we are triaging depending on the priorities of airway breathing circulation. طيب طبعا again التروماتيك برين انجري ممكن في الغالب في حالات الوور والconflict zone it will be penetrating injury due to maybe bullets, missiles, shrapnels, blast injuries and so on. وطبعا most of these patients في بعض الأحيان زي ما احنا شايفين في بعض الأحيان في بعض المرضى ما بتقدرش توصل المستشفى. ففي عايزين نقسم المانجمنت as pre-hospital management, or if the patient can't reach the hospital what we can advise the pre-hospital team what to do. And we also if the patient came to the hospital and we have no facility like CT scan, what we'll do. And if the patient reached the hospital and we have the facility of CT scan, what we'll do, and so on. And again, we are now speaking for the people, non-neurosurgical people, that how to deal with traumatic brain injury and lack of neurosurgeon. طبعا mechanism of injury is very important. يعني على سبيل المثال لما في واحد بيبقى involved في explosion، ايه اللي بيحصل؟ أول حاجة في forces from the explosion will be put into his body that causing internal damage because of the pressure itself on the body, in his brain, in his solid organs and lungs and so on. And it can cause tear for the vessels as well. This also power it will ان هي هتدفعه وكمان يتبع، يعني ممكن it will expel him or move him to a different place and hit him against things as well. So this can cause fractures, and these fractures could be in his skull or spine and so on. And also the shrapnels or the missiles from the explosion might penetrate the body of the patient. So the multiple mechanisms. Also burn itself, it can burn him and cause inhalational energy and so on, which is not our focus now. So the distance between the patient and the explosion is very important to delineate what already happened or to think about what mechanism. And it will be always multiple mechanisms of injury. It's not only one mechanism, it's multiple mechanisms at the same time that caused the injury or insult for our patient. في external signs دايما بتبقى بتقول لنا انه العيان ده غالبا عنده problem in his head. حاجات زي اسمها raccoon eyes اللي هو سواد حوالين عينيه pre-orbital edema and bruises sorry، وباتل ساين اللي هو سواد ورا ودانه ومع swelling، دي pointing to skull base fracture. ممكن يكون العيان ده عنده some sort of leakage of CSF from his nose or ear, which also pointing to skull base fracture and head injury. Or he can having an obvious deformity over his skull or scalp laceration or penetrating injury to his head and so on. So all of that also will tell you that this patient has a problem in his head. And we are speaking now before reaching to the hospital, because now we are dealing as a pre-hospital management. There are, for example, if I'm speaking to a pre-hospital personnel that he can't understand GCS, what can I say to him? He can make it as very simple as abbreviation AVPU. A, that means that the patient is alert, speaking to me well. معناته إن هو عنده good cranial circulation and he has no serious injury, or he doesn't need an immediate intervention now, as long as he remains intact in terms of alertness. Or the patient just responds to verbal command. So he won't do anything spontaneously unless I ask him verbal command, please do this, please do this. He will start to communicate. Otherwise, he will stay without any active conversation or active movement and so on. And P will be for the patient that responds to painful stimuli, and U will be unresponsive patient. And then we can divide these patients according to these as pre-hospital. So the patient that he will need less attention. However, the VPU, as you know, will depend. The severity will be getting worse as long as he is becoming less responsive. Normally, these all people also will treat them as ABC. So normally we'll ask the team to protect, make sure the airway is patent with cervical immobilization, breathing, circulation, and so on. All right. There is also some checklists that could be helpful in terms of handing over that patient or giving information that we can train pre-hospital people on it, which is I stands for what injuries the patient got, E stands for what your evaluation, and this can be abbreviated as HEADS. Head, it will be if the patient got headache, vomiting, if the patient, E for ear ringing or any ear leakage or CSF fluid, A if the patient got amnesia or loss of consciousness, and so on. D will be for double vision or dizziness. S will be for something feels wrong or if he feel not right. And D will stands for the involvement and the distance of the victim from the for example, explosion or the collapse of a building and so on, and also about the mechanism of injury. Again, this is pre-hospital assessment. So we mentioned that mild, moderate, severe head injury depends on GCS as in-hospital assessment, which depends on the GCS outcome. GCS above 14 and 15 will be mild. Between 9 and 13, this will be moderate, and 8 and less, this will be severe. And 8 and less normally necessitates to secure the airway in trauma situation. Here we assume that this patient is outside the hospital and he can't reach the hospital, and we just have some communication with the pre-hospital team that can reassure them about how if this patient has mild, moderate, or severe head injury. For example, the people that they have mild head injury, they normally have some symptoms which include no or only briefly few seconds to make blurry visions, that which is improving. No, if the patient has memory problem between 24 hours to 7 days, or loss of consciousness more than 30 minutes but less than 24 hours, confusion or deterioration that could be more than 24 hours but less than 7 days, all of that will be considered as moderate. And again, we are speaking for the people that they can't reach the hospital for some reasons. If the patient got severe traumatic head injury, which will be confusion and iteration persists that more than 24 hours, or loss of consciousness more than 24 hours, or problem with his memory more than 7 days, that we assume or we consider this as severe head injury. And these people will need attention more than the previous two categories. What is the red flags for the people staying remotely away from the medical services? If they got deterioration in their level of consciousness, if they got double vision that persists, increased restlessness or competitive or agitated behavior, that they got repeat vomiting, or they have some evidence in their scans or any medical device or any detection devices that showing that the patient has a structured brain insult. If the patient is seizing, or he got some progressive weakness or tingling in his arms or legs, or severe or worsening headache. I know this all, a lot of information, but to sum it down, so لو العيان اللي عندك حالته بتتدهور من سيء لأسوأ، سواء كان مشاكل في مستوى الوعي أو مشاكل عصبية إن هو مش قادر يحرك إيده أو رجله، أو الحالة بتتدهور أو بيحصل له تشنجات أو عنده persistent vomiting which is not improving with headache, all of these pointing that the patient has brain insult, and these are red flags that this patient will need some care for his brain and some assessment by neurosurgery. طيب ايه اللي ممكن نعمله في البري هوسبيتال مانجمنت؟ اول حاجه again ABC، وطبعا we have to control any kind of hemorrhage حتى لو من الهيد. على سبيل المثال لو العيان عنده bleeding from scalp, close the wound or at least put a pressure dressing on it until you will be able to debride and close. Tranexamic acid in the first 3 hours is important. 1 gram can be given, and then you can give him another 1 gram infusion later on. And if the airway needs securing, desecure it as part of ABC. And oxygen is important. We need that patient oxygen to be above 90 always. Normally it will be above 96%, but we won't be happy with 100% all the time as the patient is saturating well. Why? Because this will cause vasoconstriction, and this vasoconstriction will decrease the cerebral blood perfusion later on. And also it might affect his lung badly as alveolar collapse. So we need the patient to be above 96%, but we don't need to him for a long time at 100% oxygen. And we, as ATLS, we have to prevent hypothermia. We will then need to transfer him, if possible, to a neurosurgery unit. I'll just go quickly here. For example, if the patient has herniation syndrome, how will we know herniation syndrome? That the patient has deterioration in his conscious level, unequal pupil, ipsilateral dilated fixed with lateralization sign, that pointing that the patient is going to herniate. And he could have something named as Cushing reflex. What is Cushing reflex? The patient will have high blood pressure with bradycardia. It's because the intraocular pressure is very high, and the patient trying to exceeding that pressure by driving his MAB, which is mean arterial pressure. So it's trying to overcome the intracranial pressure, high intracranial pressure. So all of that, how to manage it? So this patient needs to have a dehydrating measure. So what's the dehydrating measures that we can give? The dehydration measure that we can give, it will be something like hypertonic saline, which will be preferable given in the situation of head injury and trauma. Why? Because it will replace volume, so it will give him volume, and also it will do an osmotic, so it will decrease the intracranial pressure by absorbing water from the brain itself. طيب ليه احنا بنفضل الهايبرتونيك عن المانيتول؟ لانه المانيتول اتس دايوريسيس، فهو في النهايه هو ممكن يقلل الانتراكرينال بريشر، لكن هو كمان ممكن يقلل البلاد بريشر لانه بيعمل دايوريسيس. ف the volume won't stay in his blood. The volume will be go to his, as to go to as urinary output, and then we will have a problem in terms of shock management if the patient in shock. كمان المانيتول في مشكلة تانية إن هو ممكن يعمل ريباوند فينومينا. يعني لو إحنا ادينا كذا مرة مانيتول، ممكن مانيتول ده في اللاك اوف بلاد برين بارير يروح للبرين نفسه، وكمان it will cause more swelling rather than helping in improving the intracranial pressure. However, if you don't have anything other than mannitol and the patient not in hypotension state, you can give mannitol, that's fine. طيب الميزة الثالثة للهايبرتونيك saline that we can monitor it later on. ازاي بمونيتور it؟ بنشوف الصوديوم ليفلز سواء في ABG أو VBG أو في اليوريا electrolytes. We can check the sodium level and then even we will have more window لو هو مثلا عنده normal sodium levels to give more hypertonic saline if required. الانتي سيجر ميديكيشن prophylaxis very important لو المريض عندي bending herniation syndrome أو very high intratracheal pressure, because we will avoid seizures that might happen to the patient which can kill him. For giving him anti-seizure medication will be important. Head elevation and lack of hypotension مهم. يعني العيان بتاعي لو blood pressure بتاعه maintained, I can raise his head. Sometimes also the collar itself might cause high intracranial pressure, so we can release it and put instead a head blocks to hold his head in place، لأنه ده ممكن برضو بيقلل حوالي intracranial pressure about 5 milli-mercury. The other parameter is hyperoxygenation or normocarbia. What do we mean? That we could hyperventilate the patient. If the patient got a tube, so we'll aim for his carbon dioxide level to be within normal or just in the lower range. Or if he's not intubated, we can ambu bag him about 20 breaths per minute with high flow oxygen just to wash the CO2, and this will help in decreasing intracranial pressure. Okay. Again, this is what we have mentioned. Okay, so how to manage open skull injury without CT scanner? As we mentioned again, most of head injury in war will be open head injury, and mostly it will be penetrating head injury with open skull. So sometimes you might have an underlying skull fracture as well, and this underlying skull fracture could have some dural breach or not. So this depends about if you can see brain through or if there is any fluid leakage from the wound itself. And also, so the main purpose of management of any open head injury will be to decrease the infection rate. We are not going to change the damage that happened. It's not really important to take every single piece of bone went inside the brain or any shrapnel that went inside the brain, or what we need to do to close that wound and avoid infection. This is the main purpose. So either you can do something for that wound to do further debridement, or if there is any depressed fracture that you might be able to raise it, and we'll discuss that shortly. And we will discuss the principle about how to manage that. But just the bottom line, what we normally do, even in higher center, we just want to decrease the risk of infection and to close that wound. If we are able to debride and raise the depressed skull fractures, that's fine. If we are able to repair the dura, that's fine, and we'll know how to do that in a sec. but the aim is to decrease infection. So all about closing the wound properly. And also, there is risk of having seizures with that kind of penetrating injury. So normally, we will give the patient anti-seizure medication for about a week to decrease the risk of having early seizures, because there is no evidence by giving regular anti-seizure for more than 1 week that it will decrease delayed seizures. انا بس عايز اوريكم شويه اشعاعات. انا مش عارف قد ايه انتوا النولج بتاعتكم يعني في to look into X-ray بس CT. See, it's very obvious here that this is a brain and there is a lenticular shape hyperdense pathology which is acute extradural hematoma pushing against the brain. This can cause for clinically, you can find the patient with deterioration in his conscious level or he might have a lucid interval. What is the meaning of lucid interval? That he will have initially loss of consciousness, then he will regain his consciousness, then a second loss of consciousness. This is very rare though. However, these signs of extradural hematoma. So this patient might have also a unilateral dilated pupil on that side with a contralateral weakness on the other side, which is lateralization sign. So what we need to do for that patient, we need to take that hematoma out. How to do that, we'll know in a second. You don't have a scanner, for example, and you have lateralization sign. How to know what is the problem? Also, we'll know that in a second. Again, this is another scan. For example, if you have a CT scan showing that extradural hematoma with a fracture there, and also we'll know how to deal with that in a second. This is a acute subdural hematoma. It's a semi-lunar or crescentric shape, which is crossing the suture line. In the previous one, normally this won't cross the suture line, and normally this will happen due to middle meningeal artery injury or one of the dural artery injury. However, sometimes might happen due to fracture of skull or sinus injury, but this won't be a massive or significant bleed. If it's happening due to, this will be slow building up. But in arterial, it's meningeal artery, so the patient will continue to deteriorate and he might have ankle herniation, then he might die if not treated. As you can see, the area which is hypodense, sometimes it might be hyperacute bleed. So that means it's still fresh blood, which just flowing. That's why it seems like an old blood. However, it's not old blood. It's an acute bleeding. Again, this is just to make it easier for you. So this is acute subdural hematoma. This is extradural hematoma. This is also an example for a penetrating injury, and this is after surgery. However, why I'm showing you that we don't need to take that bit out. We don't need to go after it, even in a higher center, unless it's in a less elegant area. I mean, لو هو مش في مكان مثلا زي الموتور كورتكس, the frontal cortex on the right, that's fine, that we can go after it and get it out. ايه الهدف ان احنا to get it out؟ الهدف اول حاجه ان احنا تكريز الانفكشن، لان ده ممكن يبقى فوكس للانفكشن. الهدف الثاني ان الميتال ده ممكن اولا العيان ده مش ممكن تو موف انسايد، والعيان ده مش هينفع ان هو يعمل MRI بعد كده لانه ده ميتال. it might not he might not if he need it in the future. والهدف الثالث انه احيانا في منها بيبقى بعض انواع البوليتس او الميسلز that it has poison within it or it might dissolve inside. That's why we have to take it. لكن كل الأهداف دي أهمهم والهدف الأساسي فيهم الانفكشن، وبالتالي أنا مش محتاج أبدا في الأكيوت سيتنج أو لو أنت non surgical trainee to go after that. What I need just to close the wound, just to avoid any further infection. Later on, in future, if this needed, we can take that out. Or if it caused an abscess inside, we can go after it. You don't need to go deep into the brain. Just close the wound. Again, this is a penetrating injury with different forces and a lot of scalp edema, and it's going all through. This is a bone window, this is a brain window with multiple shrapnels inside and even migrating one there in the back. Very nasty head injury. Also, again, the rule will be in the acute phase just to close the wound and avoid further infection and manage the intracranial pressure, which will be managed medically, and I will show you shortly what we can do for that. Another penetrating injury with a bullet. الامبورتنس هنا اللي انا عايز اتكلم عليه في الشريحه دي انه واحنا بنبص العيان ده البوليت just in the midline, and in the next few slides we will understand ايه اهميه الميدلاين. الميدلاين ده it's very nearby to the so this is the inlet and this is the outlet, and the inlet it's nearby to the superior sagittal sinus. It's just went off the superior sagittal. If it's on the superior sagittal sinus, we'll have a massive bleeding from that wound because of injury to the sinus, and this might not be easy for non-surgical person to treat that or to manage that. However, he was lucky enough that it missed the superior sagittal sinus and it just went off the midline. طيب الحاجة التانية إنه إحنا the other vessels it could be at risk. إحنا في الحالات دي لو إحنا عندنا أنجيو بنبقى عايزين نعرف إنه الارتريز والفينز it's يعني was injured or not، لأنه دي برضه it's one of لو أنا عايز أعالج العيان ده surgically or he might develop later on a pseudoaneurysm with the injured vessels as well if it's partially injured. As long as it's away from the major vessels and as long as I'm not going after all of that, no one will go after all of that shrapnels in his brain and bleeding and all of that stuff. The only thing that we'll do, we'll just debride that and close the wound. Because if we will go after all of that, we will cause more deficit without making him any better. Okay? Again, this is penetrating injury with a steel bar. فده طبعا واحد داخل السيخ ده كله في دماغه. طبعا عشان برضو يعني عشان أوضح إنه إحنا في النهاية بنعمل angio scan for that patient just to make sure إنه this part is away from vessel. Why he survived? Because it didn't go into one of the major vessels. He luckily survived because they were able to take that bar without injuring the vessel itself. كل الأمور دي أنا بس بقول لكم أرضية علشان إحنا في النهاية عايزين نشوف إحنا ممكن نعمل إيه جراحيا as non-neurosurgeon for that patient. Again, this is subdural hematoma. أوكي. إحنا دلوقتي ما عندناش CT scanner. هنعمل إيه؟ لو العيان ده عنده lateralization sign وإحنا يعني what is the meaning of lateral؟ عنده unequal pupil, ipsilateral, contralateral weakness, deterioration conscious level, and now we don't know what to do for this patient. So in the past they were doing extraparietal burr holes، يعني بنفتح burr hole في أماكن معينة على السكال هنشوفها دلوقتي، وممكن إن إحنا وهنشوف برضو إزاي هنفتحها، وممكن نشوف هل في bleeding ولا لا. ولو في bleeding معناته إن إحنا we need to open craniotomy over there to get that blood out. لأنه في acute blood it's not fluid, it won't be fluid, it will be very solid blood. So we have to open a wide opening to take that hematoma out. في حالات brain contusion, this means that you might decompress the brain. If you have lateralization, you just take the bone in that side out to decompress the brain and to open a big window for the brain to have more space in order to recover, and then we can replace that bone later. ما اظنش انه يعني انت هتحتاج to go any after contusion to take it out or any after intracerebral hematoma to take out, because this won't be an easy task for non-surgical trainee, but for non-neurosurgical trainee. However, for surgical trainee, he might be able to do decompression for the patient, knowing the principles of that surgery. And again, we are speaking as in war zone, no available neurosurgeon, and the patient, if left alone, he could die and you might offer him something to support him for the first few hours to days until he will get the proper management which will be required. طبعا the main aim will be to control the intracranial pressure and to avoid any secondary brain injury, and also to avoid any brain herniation, as I told you and I showed you in the previous slide. And we can also offer some medical management, which we'll speak on it shortly. The principle of management, I'm sorry, I'm very busy. I'm very busy. Principles of management, again, as we mentioned, A, B, C, D, always. And we want to know the safe entry zone, how to enter the skull, and how to close the injuries, the penetrating and perforating injury, how to raise the breast skull fracture, how to do the expiratory burr holes, and craniotomy versus decompressive craniotomy, and always leave the brain alone. You don't need to play with the brain, just you need to hemateua out or to decompress the brain. No need to do anything to the brain. Aim to avoid infection and to decompress the brain, avoid any further damage, and avoid the secondary brain injury. What about the medical management? Just to go through it quickly. Again, we mentioned tranexamic acid. This will help for managing of any bleeding, because this will help in coagulation. And we can also, if the patient on any anticoagulant that we are aware of, we should reverse that. Dehydrating measures, as we mentioned, we could use mannitol or hypertonic saline. This hypertonic saline, it's 3%, 5%, or 30%, and the dose of hypertonic saline will normally be of that 30%, about 15 to 30 ml, slowly given over 20 minutes to decrease the brain swelling. This can be repeated according the sodium level and the patient needs. Anti-epileptics, we have normally nowadays we use more and more Keppra in terms of loading. In adults, we can give 3.5 to 4.5 grams as loading dose, and then we can prescribe 500 milligram 3 times a day. We can use also sodium valproate, which will be 600 to 100 milligram as loading dose as well, followed by normal daily doses. And we can use also ipamotine, which has a lot of side effects that most of people will avoid using it in these days. Ventilation, again, we can use ambo bag ventilation if the patient not tubed, or if the patient's tubed, so we need him, we keep him normal carbia. And we can use sedation or muscle relaxant in some situations if we have the capacity to keep the patient asleep. However, if we don't have capacity, we normally in the mass casualty, we aim to wake patient to assess in neurology, and because we don't have enough critical care beds, so we treat and wake as soon as possible. Head positioning is very important. So if the patient maintaining his head, his blood pressure, we can raise his head up to 30, 40 degree. Sometimes we can sit him up. We can remove the neck collar if in case the persistent high intracranial pressure, if we have worse, and put some head blocks just to keep his head neutral if we are not sure about his neck. And we can use monitors, which is intracranial pressure monitors, and I will show you what kind of monitors we have and how to insert it quickly. And the EVDs, which is external ventricular drain, this is a drain connected to the ventricle of the brain that can drain some CSF, which will help in very high intracranial pressure. And normally you will need to have a scan for that, just to delineate the ventricular size and also to make sure that this is the proper action. So normally you won't put an EVD without having a scan. So if we don't have a scan, we normally do the decompression techniques. But if we have a scan and we think that this patient might benefit from EVD to manage his intracranial pressure, we can insert that. Also, this is not easy for non-neurosurgical trainees, so we won't speak about the how to insert it. So the main thing is avoid major venous sinuses. I will show in a picture in a second how where it should be in surface anatomy. And also you should avoid elegant areas like motor strip. So we don't normally play or manipulate in that region or put holes over it, because it might end by injuring it and cause more damage. And then the patient will have a significant deficit because of the intervention itself. We can speak also about how to repair the dura. And if there is any case of scalp loss, we just need a principle about what we normally do. Again, aim of surgery, again and again, it's, for example, if it's penetrating injury, is to decrease the risk of injury and to debride and remove devitalized tissue, accessible bone fragments if possible, or accessible foreign bodies. And hemostasis, and I can run through some hemostatic materials that we normally use in neurosurgery, and we normally close in layers. If we have multiple layers, we normally close these multiple layers, because this will give more, or better closure and avoid infection. About how we can also move some flaps in terms of loss of the skin as well, which will help as well in avoiding intracranial infection. And again, we will wake the patient up as soon as possible, particularly if we have no capacity in the critical care. I just will go first to show you the dangerous area, and then I will go back to show you how we do that stuff. So this is a lateral position, and this is the midline of the patient, the front and back. So sagittal sinus, normally it will be in the middle of the skull, just above the nose, running across to the back, and then will come to the back of the skull, just above the posterior fossa, and then we'll go to the right and left transverse sinus to the jugular vein there. All of these area you should avoid, because if you open any opening over this area, this will cause a significant bleeding. So this is what we name a dangerous area. Again, you can see there, I will show you in the AP. So all of between these eyebrows in the middle, back to the skull, and from the sides here, from the sides just behind the ear, and down to the neck, all of these areas are sinuses. So if you open any hole there, it might end by massive bleeding that it will be very difficult for you to control. So you should avoid opening any burr holes in that area. Otherwise, in the convexity here, in both sides, you might be able, as long as you are above the ear here, and off midline about 2-3 centimeters, you will be able to open burr holes anywhere. Secondly, where is the motor cortex? Roughly, this is the ear pin. Motor cortex will be here, just above the ear pin. So also the area, when you will be dealing there, you should be very careful of injuring any brain underneath. So if you are able to do burr hole away from this area, this will be better, because you will avoid injuring the motor cortex. Okay, there is another principle also you should consider, which is the blood supply of the scalp. When you are opening the wound, for incision in the scalp, you should be aware about the main blood supply. So the main blood supply, the first one is the superficial temporal artery, which is running in front of the ear, and there is occipital artery running behind the ear, and there is supraorbital artery running just above the eye. The main one, giving most of nutrition to the lateral aspect of the scalp is the superficial temporal artery. So normally we won't do cuts that will go and cut through it. We normally go something parallel to it, or like linear incision, or reverse question mark incision, as I will show you in a sec, and so on, to respect the blood supply. A second thing also is important is the facial nerve, which is running, and just 1/3 in front of the ear, between the distance between the eye and the ear, 1/3 away from it. So this will be the one of the branches of the facial nerve, which is be running there. So normally we also want to avoid cutting that nerve because it will cause some facial weakness there. So these are the main principles that we should think about. Okay, so this is roughly also this frontal, parietal, occipital, temporal bone. And we normally, we know now that the sagittal sinus running this area, backward there, and then it will come up to here to the inion, then will be divided into right and left transverse sinus, then sigmoid sinus, then go to the jugular foramen to be jugular vein. We can put bell hole anywhere here. However, we should also avoid what is known as well the air sinuses, which is the frontal air sinuses. It will be above the eyebrows and in the middle, and the mastoid air sinuses, which will be behind the ear, because if we went into these, we might cause also infection, and we might cause also C-septic leak, because the fluid from around the brain might go into the air sinuses and then leak into the nose or ear from the mastoids. If this happened, we have to seal it with sealing, to put some muscle or fascia, or there are some materials that we can close it with. So we don't need to go to that point unless we went there by mistake. But I don't think we should go there if we can avoid that. Okay, so there are some keyholes. I don't think this, I don't want to go into very detailed stuff, but there are two main bear holes that we can put into the skull, which will be McCarthy bear hole, which will be here over the, just behind the orbit. And we can drill a bear hole there as exploratory bear hole to see what's going on. So I will tell you how to do that in a sec. And we can put also maybe temporal bear hole to see if there is any hematoma in the temporal region. We can put anyone also in the convexity to drill there and then open. If it's extradural, normally you will find it just underneath the bone. If it's intradural, so we have to make a cut into the dura and then buzz the edges with the pipe holder to explore if there is any hematoma underneath. We don't need to do any of this unless the patient has a lateralization signs and we don't have neurosurgeon. Okay, coming back to the, I think we will need, in case if we will take that lecture later after to a mini course about neurosurgery in conflict zone, we can do this in mannequins, and you might get more familiar about all of these techniques. Okay, I want to show you some. So this is the incision. How to do the incision? So the incision, we have different kind of incision. Normally in the trauma situation, we will do that reverse question mark incision, which is just in front of the pinna and then above, and then go back and then go parallel to the midline, about 2 centimeters of the midline. And why we do that? It's just to make it big flap in terms of you want to decompress the brain, so you will do that and then reflect that anteriorly and then do your bear holes, and then afterwards, if there is any hematoma, you open a craniotomy, as I will show you. Also, you just be aware about the scalp layers and what's in. So the scalp layer, it will be first, have multiple layer of, scalp with the subcutaneous tissue, and then there will be and galea and the periosteum, and then the bone, which is the skull itself, and then the dura, which will be two layers, and then you will have the subdural space and the arachnoid. This is the midline, so this is the sinus, which is the layers of the dura will be split to form that sinus. So normally we won't put any burr hole in the midline. So of the midline, we can open the skin, then we'll drill the dura, drill the bone down to dura. If there is extradural hematoma, we will see it directly without opening the dura. However, if there is subdural hematoma, this is the cause of herniation or the high intraocular pressure. So you will find a hematoma there that you can take part of it. If possible, if you can't, so you will extend this as craniotomy. I'll just go back to my slides again. Okay, so in terms of how to do the procedure, so we have to put patient in position, and the positions that we got many positions, but most of cases you will be able to do it in supine position with head support in head ring or horseshoe. This is a head ring. There are many types of it. If you don't have that, you can do one as a donut. You can even do it, fashion it yourself with any bed sheet or so. And this is a horseshoe if it's available, which can be connected to the table, and the head can rest here, and we can position the patient like tilt his head to the other, depending on which side you are operating. You can put some shoulder support underneath to be able to tilt the head more to the other side to be able to reach as much as you can from the skull. And this is which named as Mayfield. There are some bins that we can put the head in. Normally there is a pediatric version, but I'm speaking now about the adult version, that we can put bins into the head if it's available to position the head even in prone position, so the head will be put there. And also the same principle, we shouldn't put these things over sinuses, these bends over sinuses, because this might break, or over a thin bone like the temporal bone, because it might break the bone and then you will have a problem. And it should be perpendicular in each other. So it should, so it's a pressure against the head itself. So if that pressure is not going in forces that going against each other, you might harm the patient or cause fracture, or the head might slip in between these bends. I don't think you will reach that point to fix the head. So normally, most of cases as well, you can depend on the horseshoe or the head ring, or even you can fashion one there locally just to sort out having decompression or burr holes. I'm just for a matter of for your information. And there are some equipment that you will need to know. Again, we are dealing now in a war zone that you might find the electric drill. So we have to go back in the history using what's named Hudson drill, which is a handle apparently. And this handle, it has a connection here that we can connect it there. And it has different burrs. And these different burrs can be connected, and then you can just use it to drill a hole. You start by this, and then if you need a small hole, you can use this one. Or if you need a big burr hole, use that one. And it's just handheld drill that you open the skin and then just drill the bone until you go through, and then you take that off, and then you find yourself either on the hematoma if it's extradural, or on the dura. This is named as Gagely saw, which is a saw that this is a saw and these two handles, and we can connect that handle to the saw, and you have to protect it with a passer. This passer actually, after you put the holes, so normally again, you won't do that in this, you won't do a midline per hole. You normally, so this is, you shouldn't do that. However, I just for a matter of explanation. I found that photo there, so I just brought it to show you. So this is the passer. You can just put a burr hole here and another burr hole and another burr hole. Then you need to connect that. So you will pass that between the two burr holes, and then there is a connector there that you can attach the giggly saw to it, and then pass it to the other side, and then you cut. انت بتستعمل المنشار ده فوق الجيجلي سو علشان يحمي لك البرين ويحمي لك الديورا. This names and as bone nibbler. So this دي ممكن نقطع بيها البون لو انت عايز توسع الفتحة بتاعتك، او عايز تكسر تقضم بون او تقطع بون، فدي بتساعدك في هذا الامر. ده كاريسون، وطبعا هو مصمم ان هو يكون ليه زي فوت بدل كده لحته دي protecting the brain and dura. فدي احنا بنستعملها، بندخلها تحت البون وبعدين بيقطع لفوق. هو يعني دي بتنزل، فهو ما بيدخلش لجوه. هو المفروض يعني ده ثابت من تحت العظمه، وهو الجزء ده بينزل يقطع العظمه وتاخدها لبره. ده برضو اسمه كاريسون، وده بنستعمله في ليه different sizes، وده بنستعمله برضو to wide the burr hole, or we use it in a spine, we use it in different way. I'm just making you familiar with the equipment that you might need locally to do that. ده اسمه pituitary ronger. It's also to hold stuff like soft tissue, or if you want to hold, for example, foreign body, you can hold it with this one, which is also, this is open and closed, has different sizes as well. ده النوماتيك دريل، وبرضه نفسه ممكن يتركب في نوع زيه الكتريك دريل. والدريل ده بدل ما انت بتعمل بايدك، فهو ده بيستعمل البريشر بتاع الاير، او بيستعمل الالكتريكال، او ممكن لو هو الكتريكال يعني بيستعمل الكتريسيتي والسيلف ستوب. يعني انا بعمل الدريل. ده ليه جزئين، ممكن انا اوريه لك من وضعيه اقرب شويه اهو. فدي ليه جزئين، الجزء الصغير ده والجزء الكبير. الجزء الصغير ده هو جزء بيدخل جوه الجزء الكبير، بمجرد ما يوصل السوفت تيشو it should self stop. فاذا انت دريلينج بيربنديكولار على البون، ومجرد ما توصل الديورا، وده اول ما يوصل سوفت تيشو it will stop. ف it's good if you have that. If you have electricity, that's good, you can use that. طيب، بعد ما بتفتح انت بالبير هولز بالدريل ده اللي هو بنسميه هاتسون دريل، نوت هاتسون دريل سوري، مايداس. بعدين في جزء تاني من الدريل اللي بيتركب ليه فوت بيدل عامل كده، وجواه منشار زي ما انت شايف كده. ده طبعا also to protect الديورا، والمنشار ده بيمشي جوه تحت العظم، ان هو عشان يقطع. انا بس بشرح الحاجات دي ربما. فاحنا بنيجي هنا نحط المنشار ده الالكتريك دريل وتحت العظمه فوق الديورا علشان ما نقطعش، يعني don't disturb the brain. you cut in between two holes. you create the holes with the electric or handheld drill, and then you move on. انتوا متابعين ولا الامور عامله ايه؟ No response. Okay, so we have also different types of drills here, which is, a bit coarse, a bit, you don't need to know all of this, but it's just in case you don't have the perforator, which this one we name it perforator. You can use also that kind of drill to drill the bone, and then again connect it with that saw, which is Midas saw. My drill. Okay, again, this is how we use it. So we hold it by hand, and make the hole, and then another person can irrigate for you just because of heating and also to take the bone dust. And again, we will connect all of these holes together to open the craniotomy. Okay. Type. This is also to show you how we use it. So we have done the burr holes here. We open the myocutaneous. Normally, we'll open the skin with the myocutaneous together in the trauma situation. We won't open it in layer. We will close in layer. However, we open it as one layer with the scalp, and then we make our burr hole and then connect it with the perforator, craniotomy. Again, this is to show you what we can do. Type. For example, if we have a depressed fracture, for example, what we need to do, what we need to, normally we won't go to the fracture itself. We'll open the skin over. If it's like lacerated skin wound there, we can extend it until we will reach its edge, and then we will open holes around the fracture, and then we will dissect the dura downward there. We will connect it together, and then once we connect it together, we can take the whole bone out, and whatever can be, for example, if it's contaminated, so we'll discard it. If it's not contaminated, we can attach it together with many plates, and I will show these many plates, and then we can reapply it again and fix it to the skull and close. All right. What is a decompressive craniotomy؟ طبعا احنا قلنا decompressive craniotomy لو احنا عندنا lateralization sign وعندنا deterioration في الconscious level, we don't know what's going on. This patient might have expanding hematoma, extradural, subdural contusions. We don't know. We don't have scan. So we open on the ipsilateral dilated side, which is the opposite to the lateralized side, which is the weakness side. We open a trauma flap, which, as we mentioned again, it's reverse question mark, and we will raise the whole scalp with the subcutaneous tissue there until we reach down, and we need to put our burr holes as you see there, and then we will connect it together either with, طبعا لو احنا هنستعمل جيجلي سو هنعمل هولز اكتر من دي عشان نقدر تو باص الباصر بتاع الجيجلي سو، وبعدين نباص المنشار وننشر بايدينا. اذا مش ممكن، او اذا عندنا سوري الكرينيوتوم، فوي كان use it to fashion by the perforator the burr hole and then connect it with the craniotomy and take that bone out. الشكل اللي احنا عايزينه ان احنا ناخد البون ده كله، we put it outside and we open also the dura, because the dura is very tough membrane. If we didn't open it, so we didn't do proper decompression. And normally we will take the bone down to the skull base, do hemostasis, and I will show you some hemostatic material that you can use, and then you can then close the scalp over the open dura. Sometimes you can layer some Surgicel over there, or if you don't have, you just close it over. The main purpose, don't play with the brain, always avoid brain. Just we need to open the covering to give the brain space and then close the skin, and that's it. This is also how we do it. So we'll open the scalp with the muscle reflected down, open the craniotomy, decompress. If there is any hematoma, evacuate. If the brain, for example, if I got an extradural hematoma and I evacuated it and the brain actually was lax, so it was depressed and there is no swelling. So at that stage, I might replace the bone again. I can put the bone, fix it with many plates. I will show it in a second to you. And then we'll put that close as normal, and that's it. If I want to take that bone out, where to put it? If it's clean, it's not broken or not contaminated, I can put it into the anterior abdominal wall. So I will make an incision, for example, in the left upper quadrant, big enough to take that bone in, and dissect subcutaneously, put it there in a pocket and close. In some situations, I can't put it there, but I have a fridge that it can be labeled by the patient details and put in a fridge in -80 degrees. This can be stored there as long as the fridge, no electricity cut, and it's working all the time. So we can store it until we can replace it in a few months back. Or if you have no other option, you can discard it, and then we can put a cranioplasty later on when this will be used. There are some also things that we can put over the dura, which could be DuraGen or gel film, or we can put Surgicel after the dura opening. And the dura opening could be in crochet fashion, or could be also in C-shaped fashion like this shape. So we can remove the bone and then open the dura in C shape, and then this in decompression for the brain. For example, if there is any subdural hematoma, so normally we will go into the subdural space to take that hematoma out, and also if the brain is swollen, because normally in the subdural hematoma, it's not only happen because the bleed, it's having because the forces over the brain, which can cause swelling in the brain. So in these people, they might need decompression also rather than evacuation of hematoma only. Again, this is a shape before, how we mark the incision, and then after closure for a decompressive craniotomy. Rarely, we will need a posterior fossa decompression. This could be challenging. I won't speak about that now, but it's the same principle. We have to avoid the transverse sinus and sigmoid sinus, which is vessels. The veins will be there, which can cause significant bleeding. And after, we can decompress the posterior fossa underneath if there is any hematoma, either extradural or subdural. And this is rarely compared to the supratentorial bleed. Okay, so if we have a defect in the dura, what we should do? So for example, if you have a depressed fracture like that, which the dura is breached underneath, what we will do? So we can do different things. First of all, if we don't have any material substitutes to put it there, like Duragen or some Surgicel, or we can leave it alone. We can leave it without any cover, and then just, if this bone can be replaced, that's fine. If not, we can take that bone and discard it, and then close in layers, no problem. Again, our aim to protect any further damage and avoid infection, and that's it. For example, if it's a big defect and you are worried about leak, or you still have a clean incision, you can still take some graft from the pericranium or from the gallia itself and suture it to the dural edge by 3O vicryl, so to close that defect, and then layer closure for the skin. I will come to that in a sec. I just want to show you some of sealing materials as we spoke about. So this is a Surgicel, which is a mesh of oxidized cellulose. It's working as a hemostatic material. We can use it as well to layer over the dura, and it's a mesh that blood will trap there and cause clot. And this Flucil, which is thrombin actually, and this is also sealing material. In case of you have bleeding, you can apply that and put some wet swab over it for 5 minutes. Then this will sort your bleeding most likely without buzzing. We normally use some bipolar, and there are kind of bipolar which is non-sticky bipolar. However, any bipolar can do, and we use it in low power. We don't use it in very high. In brain, you normally use in 10, 5 sometimes, and the maximum could be 20 if you have significant bleeding that you can't control. We can also handle things with that, so we use it even as a forceps during surgery. So we use it as forceps, and we use it for control of bleeding as well. This is Tcil, which is fibrin glue. This is like sealing material. Also, some people will use it in bleeding. However, it's sealing material, and as you see here, this is Duragen. We can, after opening, for example, this is a decompression, then we open the dura, and then we put that Duragen over the brain, and then overlay the dura over it. We don't need to suture, and we can put some glue. Normally in decompression, we won't use these things because this will limit the expansion of brain, so we just put the dura back without putting anything there. We might put just some surgical at the edge and just close the skin, and that's it. You can see here, if you are able to see, there is some stitch there in the edge, which we are naming as hitching stitching of dura. What is the aim of that hitching stitching? It's to, first of all, it's hemostatic, because if I'm near to the sinus, this might bleed. So if I make stitch there in the dura and hold it to the, either to the skull edge itself or to the pericranium, this will hold the dura there and will close the space which is causing bleeding from the epidural space. Also in extradural hematoma, if there is a lot of space, because normally the hematoma will happen make a pressure over the dura, which is pushing it in, and then we need to a bit hitch it and attach it to the skull to decrease the dead space, in order that the brain will be again back to its normal position and then fill that space. Otherwise, this space will be filled with blood and it might have recurrence of the extradural hematoma. This is also good trick in dealing with sinus bleeding. For example, if you have any sinus bleeding, what you will do, you will just hitch or put some Surgicel in between the bone and the dura, and then put a small hitch stitch just to tamponade it until it will stop in its own, because normally venous bleeding will stop with that kind of pressure. Again, this is how to store the bone. So, for example, if I got a defect of the skin itself and I have underneath a defect of the bone, what I should do? So normally we will be aiming to move some skin to close that defect, and we can even leave some raw area of bone. Or in some situation, we can take like a layer of the skin to move and leave the periosteum covering the bone and move the skin to that defect. And I think we can speak on that in a different lecture about the flaps. Normally, we have to respect the blood supply for flap when we are taking it. Otherwise, it will be a vascular flap, then it will fail. We can arrange something different about these in the future. But again, if you have a defect, you should cover it, even if you move scalp over it from a different area, leaving another raw area. Later on, we can deal with it. This is the cranioplasty, which can be different materials. We can fashion from acrylic. We can do it from titanium, mesh, or plates. We can do it from PEEK material. It's something, material that it's look like plastic, however, it's not plastic. And there is some custom bone and different types of things. You don't need to know all of that, but just to let you know that you are able even to cover small defects with some titanium mesh, or you can use some like a butterfly cover or pearl hole cover, for example, which titanium, or you can make it from acrylic. You fashion it during surgery and apply it if you need to. However, it's not a must to cover it. You can just close it without anything. And for example, if there is any herniating brain, for example, try to save as much as you can. However, sometimes it's already devitalized brain, so you can even sometimes take some contusionectomy, or you can remove it and then buzz it with the bipolar to control the bleeding, lay some Surgicel overwards, and then close. These are the many plates, and these are the many screws that we can use to connect bone pieces together and to connect the bone flap to the skull. I'm just making sure that I didn't miss any of important slides. Yeah, this one slide is important, which I told you that I'll speak about. So these are the ICP monitor. It's the same idea. There are different monitors. Some of it's intraparenchymal monitors. Some of it intraventricular monitor, which is the golden standard. And some of it's subdural or epidural. There are different kind of monitors depending on what monitor you have in your hospital. If you have that one, it guides you for treating the comatose patient intracranial pressure. Because if the patient comatose, you have only GCS, pupillary reaction, and if he's sedated, ventilated, so you don't even know if he has lateralization sign or not because he's sedated and paralyzed. So what to do? You might lighten sedation for neurology assessment, or if you want to keep him asleep for different reason, you can put an ICP monitor, which is intracranial monitor, to guide your management and to tell you if this patient has any high intracranial pressure that needs attention. And in that stage, you need to scan him if it's available, or to think about decompression or putting an intraventricular drain. It's easy to do, to connect ICP monitor. Normally, junior people can do that easily. It's a handheld twist drill normally we use, and then put a bolt in which can be screwed to the skull, and then pass a wire into it, into the brain. And this will give you a waveform that I showed you earlier, and then you can monitor the waveform, and if it's more than 20 persistently, you can think that this patient has very high intracranial pressure, so either you manage him medically by putting his head up, giving him hypertonic saline, or mannitol, giving him paralyzing material, load him with uh, Keppra, or load him with anti-epileptic, and you could take him for scan if it's available, and if this patient needs decompression or at least ventricular drain, which is the principle of putting a catheter into the ventricle to drain CSF outside to help with the intracranial pressure management. Sorry, I hope that I covered what you need to know. I'm very happy to have questions now, and we can make these as I hope that I will meet you one day in person if you need, and we can speak about these simple techniques how to do. And I think we can aim in the future to do some sort of like hands-on practice for that, for the people that they might like to serve in conflict zone area, just to have these skills with them. Hopefully it can save life. شكرا جزيلا. السلام عليكم.
شكرا، ربنا يخليك يا رب. يعني ما النيورو سيرجري سهلة اهو يعني. انتوا صعبين الدنيا ليه وعاملين؟ لا لا، بجد بسم الله ما شاء الله، محاضرة جميلة جدا، استفدت منها جدا. و اكتر حاجه استفدت منها الحاجات اللي احنا كنا بنقولها في الاي تي ال اس، اللي هو لما بتسمعها من نيورو سيرجن بتبقى مختلفه شويه. اللي هو احنا لما بنيجي ندرسها دايما او نقولها للناس، اللي هو ايه ده بجد، هم بيعملوا كده بجد، هم بيعملوا ايه فوق في اوضه العمليات بتاعتهم دي. لان هو السبيشاليتي بتاعتكم شويه غامضه كده، ولا هو انتوا واخدين جنب كده. فما الواحد يسمعها منك بيطمن اكتر يعني. وحتة ان احنا خدنا دي ستيب فورورد، ان احنا ممكن نعمل دي كومبريسيف كرينيكتومي وحاجات دي حاجة ظريفة جدا يعني. كان هو جه سؤال واحد بس، اللي هو نعمل ايه في الاكزيت ووند. انا ممكن متخيل نعمل فيه زي ما بنعمل في الانلت ووند يعني، مش عارف. انت
اه
عندك حاجات؟
بالظبط. هو الفكره، احنا الناس بتبقى وورد جدا وشاغله نفسها بالانتراكرينيال باثولوجي.
اه.
however لا انا ولا اي حد اصلا هيبقى يعني عنده قدره ان هو يعمل حاجه للانتراكرينيال باثولوجي unless it's very superficial thing.
امم.
لكن
امم.
لو هو deep seated problem we'll just manage the outlet and inlet as normal.
امم.
ده في الهاير سنترز يعني، مش
امم.
احنا will go just after the things that we can get without,
امم.
or if we have to take it out
امم.
لسبب يعني. وده كله مش هيبقى emergency. آه آه يعني احنا حتى في بعض الأحيان بنعملهم next day على سبيل المثال، وده
اه.
لو احنا عندنا الفاسيلتي. الا لو هي حاجه مثلا زي الصور اللي شفت انا قبل كده، اللي هو penetrating مثلا like ستيل، مثلا ستيل بار، او في ناس بن او نايف او وات ايفر. So
مم.
at that stage if it's still there we need to
مم.
take that out. واحنا طبعا لو عندنا facility ان احنا نشوف الفيزلز جوه البرين قبل
مم.
نشوف قبل ما ناخده، لانه احنا كل مشكلتنا ان احنا نشيلها يحصل bleeding، ف we
اه
have to be
اه
prepared for that. فلو احنا خايفين من موضوع ان احنا نشيلها يحصل bleeding، فاحنا محتاجين بقى ان احنا ايه، دي محتاجة احيانا او مش محتاجة expert person ان هو لو هي
مم.
just beside a major vessel or
مم.
beside major sinus. So at that
مم.
stage we have to have a proper control. فاحنا بنفتح فتحة تدينا الكنترول ده.
مم. مم.
لكن لو هي superficial او away from major vessel and it will be the same practice، احنا هنشيلها وهو هيشيلها يعني. بس انا مش بقول كده، انا بقول انه احنا في مواقف انت if you don't do anything for that patient he will die
مم.
and you don't have facility. I'm not saying that this practice to teach everyone to do neurosurgery cases. This
مم.
practice in case you don't have anything. This is the last resort,
مم.
and you are the only person, you can do something to save that patient's
مم.
life and explaining the aim of that.
مم. لا والله يا هالي احمد، ربنا يخليك يا رب. انا متشكر ليك جدا، وانا ما عنديش اسئله تانية على الشات، وممكن طبعا نبقى نعمل حاجات تانية. لو الفيديو هيبقى على اليوتيوب، لو الناس عايزه اسئله تبقى تسأل على اليوتيوب، ونشوف بقى لو هنعرف نعمل حاجه تانية او مطلوب نعمل حاجه تانية. ومتشكرين لوقتك جدا، ربنا يخليك يا رب.
الله يخليك يا باشا، تحت
مجهود
أمرك.
كبير.
احنا كان ممكن نتعرف الناس اللي موجودة لو هم ما لسه
هم
موجودين.
اختفوا شويه يعني
احنا معانا اتنين، لو انت هتعمل لهم unmute لو حابين
اه
يقولوا.
طبعا طبعا، انا هيندل ريكوردينج وبعد كده ممكن طبعا لو
You
هم.
can keep recording وانت you can omit